Good evening and welcome. I'm Milan Han, and I'm joined this evening by Frank Sciurba. And we're here for tonight's webcast series, Talking COPD. So the topic is COPD tonight, but specifically challenges and recommendations for improving access to evidence-based COPD management. So we're really excited to have you. As I mentioned, my name is Milan Han. I am a pulmonary and critical care physician at the University of Michigan, and I'm joined by my colleague, Dr. Frank Sciurba. Frank, do you want to introduce yourself?
Sure. Thanks, Milan. I'm Frank Sciurba. I'm a professor at the University of Pittsburgh, and I've been doing this for a long time. Milan is chair of medicine or division of pulmonary at Michigan. She was a baby in one of the projects and has come a long, long way. We're proud of her accomplishments. Yeah, we've been doing this for a while, and COPD kind of goes in cycles with new innovations and thoughts. And right now, I would say that we're in a very interesting period. There's a lot of new innovations coming. So hopefully you're interested.
Our learning objectives for the evening are to recognize the burden of disease for patients living with COPD, to understand what the guidelines have to say about diagnosis, as well as monitoring for comorbidity, to understand what the stepwise treatment plans are, as well as understanding a multidisciplinary approach for the care of these patients. So COPD is a bit of an umbrella term, but I think that well recognized that it's both common, preventable, but also quite heterogeneous. And I think that that's what can make it quite challenging to both diagnose as well as treat. From a patient perspective, it's frustrating for patients because they have persistent symptoms and airflow obstruction. And this can be due to either both airway and or alveolar inflammation and damage. For many patients, there's a role of noxious exposures, often tobacco smoke, but it could be something else. But I think we're also beginning to understand that there's certainly other factors that play a role for other patients getting COPD, including things like respiratory infections, genetics, et cetera. So, what do we need to know about COPD and its impact? Well, millions of patients who have the disease, and it's still third leading cause of death worldwide, with over 3 million deaths in 2019. It also contributes to a significant number of patients who are both hospitalized and unfortunately hospitalized, with significant economic impact. So with that, I'm going to toss the mic over to Dr. Sciurba, who's going to kick us off to talk about how we can approach personalized treatment for patients with COPD.
Thanks, Milan. So the first thing we need to do is evaluate our patients. And as Milan suggested, there's a lot of heterogeneity. And I will tell you, I've never seen two patients that are identical. You know, we have a limited number of pathways, but some patients have low oxygen levels, some are short of breath, some have a lot of cough and sputum, some have frequent exacerbations. And you have to consider all of these attributes to really deliver personalized and precision approaches. And as we get more and more tools, this is going to become a bigger and more important issue in the treatment of these patients. The first thing is to consider it, to make the diagnosis. And the American College of Physicians does not recommend wide screening with pulmonary function tests, but they do recommend case findings by identifying patients who have symptoms. Shortness of breath, chest tightness, cough, sputum production are the predominant symptoms. And then those that have risk factors, and as Milan suggested, tobacco is number one in this country. Secondhand or biomass exposure from indoor cooking is very common in poorer parts of the world. And if you suspect it, you need to get spirometry to really nail down the diagnosis. The initial assessment, spirometry. And basically spirometry is how much comes out and how fast it comes out. And the amount that comes out in 1 second, which is basically how fast, is called the FEV1, the forced expiratory volume in 1 second. And when the amount of air that comes out in that first second divided by the total air, that's the FEV1 divided by forced vital capacity ratio, when you get less than 70% of your air out in that first second, that's really consistent with a diagnosis of COPD. And patients come to us not because they can't blow out hard, but because that's associated downstream then with issues of shortness of breath, air trapping, perception of inactivity, and we need to address that. The other component is, do they have flare-ups? And that can happen independent of the severity of lung obstruction. And we're learning that's become an increasing target of therapies. Smoking status. We're not going to talk a lot about smoking cessation techniques, but the elephant in the room is always, hey, they're smokers. And if you don't address the smoking, it doesn't make any sense to address all the other issues. And to some extent, that's true. You really always have to ask, are you ready to quit smoking, and provide opportunities and suggestions and tools to help them to quit. The only intervenable target, genetic target in COPD that we know can cause emphysema and airway obstruction is alpha-1 antitrypsin deficiency, and you can test for that. So most of the guidelines recommend testing at least once in every patient who has a diagnosis of COPD for alpha-1 antitrypsin phenotype and levels. And then comorbidities, interestingly, are tightly connected with COPD. And as you'll see, there's many comorbidities, cardiovascular disease, depression, anxiety, that are linked with smokers who have COPD, even more so than just smoking. And those comorbidities cause many of the symptoms that COPD causes. So they're synergistic. And if you don't address those, you're not really addressing the whole patient. So the management of COPD goes from pharmacologic approaches and non-pharmacologic approaches, and you really have to address the non-pharmacologic approaches simultaneously. We talked about smoking cessation, vaccination. There's increasing numbers and more effective vaccinations. We'll talk a little more about that. Get up off the sofa. Often these patients won't express shortness of breath because they're not doing anything anymore. And you have to sometimes probe deeper and ask, what are you doing? And then if they're not doing things, ask why. And then you might say, well, I get a little short of breath when I leave the house, okay? So exercise training to get them that deconditioning out of the way. And we talked about managing comorbidities, and we'll talk a lot more about managing pharmacotherapy in these patients. So what are the goals of treatment in COPD? Well, the patients come to you initially because they have symptoms. And so we need to the primary target then is to reduce those symptoms, improve their activity level, decrease their shortness of breath, both at rest and with activity. Cough and sputum in some individuals is important, and we have to address that and improve their health status. But interestingly, the therapies that we have, just as in the use of statins and blood pressure medications and cardiovascular disease, don't necessarily make people feel better. They reduce serious downstream events. And our medications in COPD, we need to recognize, are increasingly effective at reducing disease progression, exacerbations, and flare-ups, which has very strong evidence base. And there's increasing data, particularly with secondary outcomes of some of the large trials, supporting a reduction in mortality now. And so I think we've gotten to that level that we can improve survival in our patients. So Milan's going to talk a little bit more about the GOLD classifications down the line, and we'll come back to this a couple of times. But we talked about assessment of diagnosing the disease with spirometry. So as far as the initial treatments in patients with COPD, we're assessing, do you have symptoms? And here they give two tools. You can use those tools. They're nice tools. The Modified Medical Research Council Dyspnea Scale, which is basically a 5-part scale. Milan will show you that. And then the CAT scale, which is a 8-question symptom questionnaire. Or you can assess your patient. Do you have cough, sputum, shortness of breath? And you get a feel for whether they have needs in that direction. And then the other major component is, do they have flare-ups? Do they have situations with increasing shortness of breath, cough, sputum that requires treatment with steroids or antibiotics? And if they have more than one of these in the past year, then they're considered higher exacerbation individuals. Or if they have one hospitalization, that's enough to put them in the higher category. And that higher category with the frequent exacerbations we call group E. I guess now it's the exacerbation category. Group A are patients who really don't say, I have a whole lot of symptoms. They have obstruction, maybe with exertion. I argue these folks are often the ones that withdraw from activity, or they're still smoking and they don't want to let you know. But there is a category of patients that don't say they have a lot of symptoms. And then group B are infrequent exacerbators who still have shortness of breath, often with exertion. If your patients are symptomatic, the standard therapy that's really evolved over the last couple of years is they deserve dual long-acting bronchodilators. And LABA is long-acting beta agonists. You know, the short-acting version everybody knows is albuterol. LAMA is long-acting muscarinic antagonist. The short-acting version is Atrovent, and there's multiple combination therapies now of LABA and LAMA. And you want to give either a twice a day or a once a day preparation of LABA/LAMA. Because if you start out with only one of those, which had been really the case in 5 years ago, I've never had a patient who's symptomatic with COPD who you can completely eradicate their symptoms. And so we may as well give the maximal therapy. We'll talk a little bit more about that. In patients who have frequent exacerbations, we'll talk about making a decision on whether to start inhaled corticosteroids as well as LAMA/LABA in those folks, or just to go with LAMA/LABA alone. But it's always LAMA/LABA with consideration of ICS in those who have frequent exacerbations. And we'll discuss that in a bit more detail. Okay, so coordinating care in COPD is really critical. And the first step is actually to have doctors present. And these graphs really show there's a lot more primary care doctors than there are pulmonologists. And pulmonologists tend to be concentrated in more urban areas. I've just had a lot of interaction and done some projects with a doctor in the middle of Nebraska who is a pulmonologist and is so overworked that most of the patients have to go through her APPs, and she sees often the more difficult patients. These patients come from ranches 50, 70 miles away and have sort of limited access. So that really tells us that the primary care docs in many areas of the country really need to understand the basic management of these patients and then know when to refer the more difficult cases, sometimes 50, 100 miles away. To develop programs and processes in their area to do the basic care of patients with COPD. There are challenges in the management of COPD. First of all, again, we're going to talk about the variation in this disease. You really have to recognize one type doesn't fit all, and understanding that variation and targeting treatment to that individual is critical. To get oxygen paid for, you have to obey the rules, and basically patients have to have a saturation either at rest with exertion or during sleep that's 88% or less saturation, or they're not going to get it paid for except under unusual circumstances. Pulmonary rehab, you'll learn, is really important to get these folks moving and training and learning about their disease. but less than 5% of patients ever get to pulmonary rehab. And part of that is related to that map I showed you. I can tell you where there's not a pulmonologist, there's not likely to be pulmonary rehab. And so to get folks traveling 75 miles to do pulmonary rehab is not likely. So we have to come up with other strategies or try and access resources, physical therapy, cardiac rehab in your community to try and get these folks to train a bit. Comorbidities can mimic COPD symptoms. And so if we're not addressing their heart failure or depression or frailty, we're not going to optimize the care of that patient. And social determinants of health are increasingly being recognized. If a patient can't afford the copay, or they don't have resources to help them in their environment, they don't have basic care to have good nutrition, or they're in an area that has high particulates and they can't escape that, we're not going to be able to address the important issues of getting these patients to their best health state. So sometimes addressing issues that go beyond just the chronic disease are important to helping our patients. So care coordination has to recognize that there's often many different professionals in the community that can help, but also there's inpatient and outpatient. And if there's not a smooth handoff after treating an exacerbation in the hospital to continue the medications or to train the patients on the medications that they're going to be using at home, we're going to drop the ball and they're going to have a higher rate of readmission. To partner with those in the community to recognize that there may be interventions to optimize those social determinants of health or their depression and anxiety, to get them to adhere to your medications and understand and educate them, to use social workers or the individuals in the rehab units to teach your patient along with you to reinforce those issues, and to have really open lines of communication between those individuals where everybody understands the same guidelines and has the same goals and uses all the resources in the community. Really critical. And so, this has to be attended to. So I'm going to hand it over to Milan. We're going to present a couple of cases that show us the different variations of COPD. Dr. Hahn, do you have any thoughts on anything that I may have missed or that I could have said better?
No, that's a great overview. And so we're going to just, I think, now kind of dig into the details of diagnosis and both pharmacologic and non-pharmacologic therapy through a couple of example cases. So moving along here, for this 59-year-old gentleman that presents to your clinic, we're going to go through just some of the information you might have available to you with some thoughts on, just kind of how to interpret that information and, what you might want to be thinking about. All right, we've got a little bit of a screen delay here. Okay, there we go. Okay, so this 59-year-old gentleman originally presents to the emergency room due to increased work of breathing. He complains about being short of breath after waking in the morning. He's short of breath after climbing a few flights of stairs, to short of breath to finish full sentences. And his wife is in the waiting room, and she mentions, he's got a 15-pack year smoking history, also has a history of liver failure and a penicillin allergy. He builds cabinets for a living and has a lot of dust and debris in his home. So definitely got some risk factors. So what do we need to think about when we see a patient like this in our office and are trying to think about some of the diagnostic challenges? One of the things I think is really important to remember is that in general, COPD is horribly underdiagnosed, and you can see in fact the underdiagnosed patients may make up the majority of the patients who have the disease, and you just kind of get a sense for what that looks like globally. So it's definitely a problem no matter where you're practicing. But when we think about who to screen for COPD, We're working on developing some tools. We don't have any perfect tools, but you want to think about risk factors and symptoms at a minimum. And as I mentioned earlier, this could be tobacco, but in this gentleman's example, it could be woodworking and chronic occupational exposures. It might be other indoor and outdoor air pollution factors. From a symptom perspective, this can be really tricky because, as Frank mentioned earlier, patients will cut back on their activity levels so that they actually don't exhibit shortness of breath. So you really have to press them not just about active symptoms, but also on how they may have changed their activity levels to potentially avoid symptoms as well. But in general, the shortness of breath for COPD tends to be progressive. It's sort of, I walk to the mailbox, I'm short of breath, I rest. It's sort of this kind of similar pattern. There may or may not be a productive cough. And then, as I mentioned, there's some of these more traditional risk factors like tobacco, but there may be things that you don't think about, like frequent childhood respiratory infections or even low birth weight. Believe it or not, no matter how old my patient, I try to get as much birth history information and childhood information as possible. So Frank alluded to this earlier as well, but this is, what we're looking at when we're trying to diagnose COPD, and we need post bronchodilator spirometry. And what we're looking at here, there's just three things you need to look at: the FEV1, the FVC, and the ratio. If the ratio is less, let's see, what have we got here? If the ratio is less than 0.7, then we know that airflow obstruction is present. But then the FEV1 itself is how we grade severity, and we do that in terms of percent predicted. And this is, Frank had mentioned earlier, is how GOLD breaks down disease severity. So this is kind of like how far is the train out of the station. And it's helpful when we think about prognosis, and patients often want to know how sick they are. But when we think about treatment, as Frank mentioned earlier, that's where we also need to think about symptoms and exacerbation history. So we've got this gentleman in our office, and we're going to do a few additional assessments. We're going to do a physical exam. We're going to, examine their extremities, look for edema, other signs of additional comorbidities. We mentioned earlier he had some liver failure. Now, I would not necessarily recommend that we need to get an ABG on every single patient, but he was in the emergency room, so we have it. And we can see that he is retaining a little bit of carbon dioxide, and his oxygen is a little bit on the lower side as well from that ABG. All right, and then we happen to have a chest X-ray, and that shows evidence of hyperinflation. Okay, I'm trying to get. Oh, and then we had a red blood cell count as well, which I apologize. I just worked through it, but it was slightly elevated hematocrit. So we're going to go ahead and open this up for a polling question. And I'm going to tell you right now that I don't actually think that there is a right answer. So A is chest X-ray showed classic signs of COPD with hyperexpansion and dark lung fields and a narrow heart. Question B, or answer B, the patient does not have a history of cor pulmonale. However, findings revealed hypertrophy of the right ventricle. C, lab values show RBC, hematocrit, and hemoglobin levels, which could indicate hypoxemia. D, the ABG indicates COPD is present because there's a respiratory acidosis and mild hypoxemia. And E, the compensated blood gas indicate an issue that has been present for an extended period of time. Okay, so again, I think these all could be relevant. Probably A is most relevant to the actual diagnosis of the patient. And it looks like that was one of our most popular answers. But questions C, D, and E, I think are all important with, making us think about whether we need to potentially prescribe oxygen for this patient. And you could also think about things like polysomnic, an overnight sleep test to try to figure out if the patient might qualify for non-invasive ventilation at night too. So there's definitely a couple of things to think about here. So, in order to evaluate a patient, Frank mentioned earlier that we've got this ABE box, and you need to look at both symptoms and exacerbation history. So, there's a couple of ways you can do that. You can do the MRC dyspnea scale, which is one way, and 2 or more on this scale is considered symptomatic. You can also do the COPD assessment test. You may be interested to know that I've recently been told that this has now been programmed into Epic. So this should be available in an easier fashion at more and more institutions across the country. But these are considered sort of the 2 standard metrics that Gold recommends for assessment. And then here again, we've got the severity, which is the old spirometry grading 1, 2, 3, 4 that many of us are familiar with. And then we break people into the high risk E group and then the low risk, low symptoms A, high symptoms B group with respect to trying to figure out therapy. So we've got another polling question here. Which test would most support the patient's COPD diagnosis? Is it A, PFT, B, CT, C, right heart cath, D, echo, or E, MRI? PFTs are required for diagnosis, so I think in that way this is right. There could be a role for some of these other things. Probably not lung MRI, but in certain cases, I think that there are roles. I think it's increasingly common that we'll end up getting CT scans on many of these patients for a variety of reasons, whether it's lung cancer screening or advanced therapies. So we want to go ahead and we get the pulmonary function testing on this patient. The FEV1 to FVC ratio on the post bronchodilator is 48, so we know that airflow obstruction is present. And then the FEV1 is 41% predicted, indicating severe COPD. All right. Get my clicker going here. Okay, you do not have to order a CT, but you have it anyway. We'll just say the ER got it for you. And the CT itself shows central lobular emphysema as well as coronary artery calcification. I think one of the things that both Frank and I have been really interested in is the fact that we're getting more and more information from these CT scans that may be useful. And so I do feed back information like coronary artery calcification to patients and talk to them about things like whether stress testing might be appropriate.
So,
Okay.
Milan, one of the things we're not going to talk about much today, but we can say maybe to the primary care docs when they've done everything we're telling them to do today, and your patient has a lot of emphysema on their CT scan and are incredibly short of breath, there are some new advanced therapies like lung reduction surgery and endobronchial valves that pulmonologists would mostly know about that might warrant referral to pulmonologists. So.
Yeah, no, that's a good point. I don't know what your rule of thumb is, Frank, but I generally tell people if the FEV1 is less than 50% predicted and the patient's got significant dyspnea and you suspect hyperinflation, that's a patient probably go ahead and refer. And they'll go ahead, when you get the patient to that referral center, they'll do a CT scan. It needs to be sort of a specific protocol to feed through the software, but they can go ahead and get that CT scan and figure out if the patient might qualify either for valves or lung volume reduction surgery, or in severe cases for lung transplant. So that's a great point. So just in summary, we talked about just how common COPD is, the morbidity, that it requires PFT for diagnosis, that we have to look for a post-bronchodilator ratio, FEV1 to FVC ratio of less than 0.7, and that early detection is really important because we do have so many patients that are underdiagnosed. Right. Okay, Frank, I'm going to go ahead and toss it over to you.
Okay. So we're going to present another case, a woman that has advanced disease and has some interesting aspects that we ought to consider. Mrs. X is a 74-year-old woman that lives kind of out in the middle of nowhere and and so she's had a lot of telephone consultations with the respiratory team. 2 years ago, she had a FEV1 of 24% of predicted. So that's considered very severe. And these folks who live a good distance away in a remote community, often we don't get updated PFTs, pulmonary function studies on them. But honestly, somebody 24% of predicted can only be worse. So we know she's in a severe category. She has a supportive daughter, which is good for her to help her with that remote situation. She quit smoking the previous year after she was admitted to the hospital, which is 50 miles away from her home. And so that results in stressful situation, to the point that she may really go to a point where she's sicker and more severe before she does seek help. And in fact, her family managed 4 exacerbations at home with a self-management plan. Perhaps if she was in an urban area, she might have shown up to her doctor's office or even been admitted to the hospital. Hard to say. And we'll talk a little bit more about self-management and how we can support patients on their own. Okay, her usual therapy consists of long-acting beta agonists, an inhaled corticosteroid combination, and long-acting muscarinic. There's devices now where you can get all 3 in the same device, either a meter dose inhaler or a dry powder inhaler, or they're available, all these long-acting agents by nebulizer now. That's an option. But the fact, and they can be closed in one device or in 3 separate or 2 separate devices. So there's a lot of different ways to do it. And we'll talk maybe about some factors that might help you decide what direction that might be. So she's really appropriately treated, a frequent exacerbator with triple therapy. She has a number of other health problems, including coronary heart disease, osteoarthritis, and her daughter's become concerned that she's increasingly forgetful. I could tell you at the top of my head, patients with osteoarthritis with cognitive issues often have trouble with their devices, and we need to really reinforce and see whether they're able to manage that. These patients often, especially the more severe folks, should be considered for one of the nebulized regimens, sometimes all the long-acting agents by nebulizer as one of the options. And that's why on a personalized level, we need to assess all of these things. She manages at home by herself, steadfastly refusing social help and adamant that she does not want to move from her home that she's lived in for 55 years. I know 20 of these people. So we have a question and a survey. What would you recommend for this patient? And again, I'm not sure we have all the information to know the exact answer, but I think these answers do contribute to a good discussion. Should she get long-term oxygen therapy, refer to a respiratory specialist and or pulmonary rehab, optimize pharmacologic and non-pharmacologic treatment, all the above, or we haven't taught you enough yet? So we don't have an oxygen saturation or level, so I can't tell you legitimately. I can tell you the vast majority of my patients that have FEV1s that low will qualify for oxygen either at rest or with exertion. Folks that get this severe with some of the more advanced therapies, I really think ought to be referred and co-managed with a specialist and referred to pulmonary rehab. Now, in the middle of Nebraska, you may not be able to get that, but to be creative and get folks with physical therapists or cardiac rehab programs and working with what you have in your community, you can sometimes crack that nut. And of course, always we want to optimize pharmacologic and non-pharmacologic treatment. So it's probably all of the above. This patient would definitely, as all patients, benefit from a review of comorbidities, the contribution of her coronary artery disease or congestive heart failure to her dyspnea, frailty, and symptoms. A chest X-ray is probably always reasonable once at the beginning. You can address hyperinflation, look for other parenchymal or lung diseases. I mean, pulmonary fibrosis is a real thing, even in smokers. And so there's other diseases that cause shortness of breath that you want to address. An electrocardiogram to begin to assess cardiac function. Anemia is common, particularly in our more severe patients, that could worsen the whole issue of the respiratory gas exchange. And hyperthyroidism, hypothyroidism should be addressed. They can cause frailty and fatigue. So all these things, addressing comorbidities, a good thing that a generalist ought to address. So furthering treatment strategies in these patients. Again, comorbidities need to be addressed. I think we've emphasized this a lot. COPD is most often associated with comorbidities. More than 50% of the patients have significant treatable cardiac disease. Osteopenia and osteoporosis are disproportionately common, particularly in emphysema patients. Muscle wasting, just due to the cachexia of the disease, but due to the inactivity is a problem. Underweight, and then obesity, to carry around the burden of extra weight when you're already have a decreased respiratory reserve is a problem. So gaining weight with frailty and losing weight with obesity are considerations. Depression and anxiety, really common problems that ought to be addressed by these folks. We talked about cardiovascular disease. One of the things that I pick up a lot in these patients, particularly patients who are beginning to have CO2 retention, is obstructive sleep apnea at night. And the two together are bad actors. So if you have a COPD patient that also has sleep apnea, that's going to be associated with significant nocturnal hypoxemia and other issues. So always consider that as something we can do for our folks. And the treatment strategies really to address all of these things. And we're going to go over these in the next slide, so I'm not going to mention them here. All right, so we're going to go ahead and ask another question. Which of the following is true regarding non-pharmacologic therapy in patients with COPD? It improves functional status, but not survival. Are not useful in patients with GOLD A or B, just symptomatic without exacerbations. May decrease post-COPD exacerbation and readmission rates, and tend to have less impact than pharmacologic therapy. All right, well, it looks like we've got a good variety. There's a even split between A and C with a sprinkling of D. And I would go with, therapies may decrease post-COPD exacerbation and readmission rates. And because there is now a trend toward improvement in survival, and actually the non-pharmacologic therapies on symptoms often are even more impactful, pulmonary rehab and oxygen therapy, than the pharmacologic therapies. But clearly we want to do everything we can for these folks. And so pharmacologic and non-pharmacologic are important. What are the non-pharmacologic therapies? Again, we're not going to go into detail on smoking cessation, but we have tools with NRT, nicotine replacement therapy, Chantix, bupropion, and just honestly bonding and reinforcing these issues with your patient and paying attention to them. Physical activity, pulmonary rehab, critical to break that deconditioning cycle and decrease the ventilatory burden. It doesn't improve lung function, but it could allow them to cope with decreased lung function significantly. Ruling out obstructive sleep apnea and treating with CPAP's important, but in patients who are CO2 retainers, we can now find ways to actually do non-invasive therapy to decrease the work of breathing at night and even during the day, which decreases hospitalization and probably survival. Vaccinations, again, not a detailed lecture. I'd add RSV to this list in your patients over 60 years old, but clearly influenza being on top of COVID vaccination, pneumococcal vaccinations, and then even consideration of pertussis, which we talk about less, and shingles vaccinations are important. Nutrition to assess frailty, weight loss, as well as weight gain are really important. And having nutritionists associated with pulmonary rehab or available independently is important. As far as co-management of cardiac failure and congestive heart failure and COPD, beta blockers have been controversial, and they've kind of gone in and out. And honestly, there's some data in both directions, but I can tell you that if it's indicated for heart failure, you should use beta blockers and not withhold them because of a slight risk of interfering with the COPD management. In blood pressure management, I would argue using alternatives first would be important, but if it's necessary, even in hypertension management, beta blockers can be warranted. But there's certainly not an absolute contraindication to beta blockers in COPD. The use of angiotensin receptor blockers and ACE inhibitors are really good drugs in COPD. There was some controversial literature that they actually may slow the progression of COPD. That's really not been confirmed, but certainly the use to treat congestive heart failure and hypertension is really important. So you get the patient. We talked about initial management. How about patients that come back to you? I'll tell you, often we can improve these folks, but often there's some residual shortness of breath, and in some cases, persistent exacerbations. I mean, I would argue our COPD patients don't exacerbate as much with guideline-based therapy as they did 20 years ago in my practices, but certainly some of these patients, despite the best therapy or certainly initial therapy, will still have exacerbations. So if they come back with shortness of breath and they're really, doc, it helped a little bit, but I'm still really short of breath. Well, if they came to you, you probably didn't put them on just a LABA or just a LAMA, because we just told you shouldn't do that. You should start them on dual therapy, LAMA-LABA. But if they started out in another clinic where they're just giving them one, you ought to go to dual therapy. You ought to make sure that device, it's often not the chemicals that aren't good for them. It's that you can't get the chemicals into the lungs. And so using the right device, or sometimes just switching to all nebulizer, these long-acting nebulizer therapies, can be the right answer. Some patients don't have enough inspiratory flow rate to activate the dry powder inhalers. Some patients have a little trouble coordinating with the meter dose inhalers. So the right device for the right patient is really important. And having your staff in the office that has watched the YouTubes that teach you how to use these devices, or actually having the YouTubes to give to the patients and tell them where to find them, can help you to improve their adherence and getting the drug into the lung. But let's say they are on the right device and it's just not good enough. Think about the other non-pharmacologic assets that we have available, pulmonary rehab, and really optimize the overall therapy in these patients. How about patients that are still having exacerbations despite starting the LAMA-LABA? Well, if their blood eosinophils are over 300, and we're talking about the CBC that you just have in your charts that your patients have likely had multiple times over the last few years. If their eosinophil count is over 300, that's an indication that they may have type 2 inflammation, which tends to be most responsive to inhaled corticosteroids. And those folks definitely should be on a LAMA-LABA ICS. If their eosinophils are less than 300, then consider, and we're assuming now anybody is going to be on a LAMA LABA who's having exacerbations, the dual LAMA LABA. But if they continue to have exacerbations on the dual LAMA LABA, if their eosinophils are really low, less than 100, you might want to just completely skip the triple with the ICS and go to some of the alternatives that we've used. They're not the greatest drugs, but they can reduce exacerbations another 20 to 30%, and that's a PD4 inhibitor, which is roflumilast, which is approved, has a lot of GI side effects. Some of our patients can't tolerate it, but the right patient can really benefit. Or daily or 3 times a week azithromycin, which has both antimicrobial and anti-inflammatory effects and can reduce exacerbation rate by about 30% in those who continue to exacerbate on the other guideline-based therapy. These are the two of the domains, shortness of breath and exacerbations, that we would consider escalating therapy. Now, what if you have a patient that's on triple therapy? They may have only had a couple hundred eosinophils, and they haven't had an exacerbation in 2 years. Well, those folks you can consider de-escalation, removing the ICS and just putting them back on the LAMA LABA. And the reason is ICS, you say, so what? Leave them on the ICS. Well, ICS can cause 2 to 3% higher frequency of pneumonia per year per patient. And so it's a small risk, but it's a real risk. And if you don't need it, you shouldn't have them on it. So de-escalation is also a thing in COPD to consider. So, this just reinforces a concept that happened really more broadly recommended within the last couple of years, and that's don't ever use single mono long-acting therapy. If you're gonna, there's devices, it's a single device, it's no more work to the patient, it's no additional cost, it's the same copay, and really the adverse effects of these drugs are minimal. So LAMA LABA, long-acting muscarinic antagonist, long-acting beta agonist combination is really the way to go. You get better improvement in lung function is proven, your symptoms are better, exercise tolerance and lower exacerbation rate. There's every reason in the world to go straight to the LAMA LAMA and implement that. Triple therapy, we've actually pulled away from adding the ICS more routinely. And patients should never be on it if they don't have frequent exacerbations. And patients with very low eosinophil counts, it's not an absolute contraindication, but we tend to drag our feet and try other things rather than adding that ICS in patients with low eosinophil counts. So LAMA LABA in everybody, it decreases exacerbation rate, and consider ICS in the right person with frequent exacerbation and higher eosinophil levels. Okay, so we're going to go with another question here. Which of the following is true about the addition of inhaled corticosteroids to a COPD regimen? The incidence of pneumonia is decreased among patients on ICS, so they actually decrease pneumonia. Should be avoided in patients with emphysema. Has been shown to decrease exacerbations, and has been shown to be useful in patients with mycobacterial infections and bronchiectasis. Okay, so you're either smart and don't need this lecture, or you were listening to me. Everybody got it right. Has been shown to decrease exacerbations. So that makes me feel good. We're going to treat our patients appropriately out there. Okay, factors to consider. We're going to reinforce this concept of when do you give inhaled corticosteroids. Strong support, frequent exacerbators, 2 or more exacerbations per year, or history of hospitalizations, high blood eosinophil count, greater than 300, and then a history of high variability, significant allergy history, bronchodilator reversibility, childhood asthma. Those issues are associated with a combination of an asthma overlap syndrome, which always warrants inhaled steroids. Patients that should never have steroids are those that have had repeated pneumonias with very low eosinophil count, and particularly those with known mycobacterial infections where inhaled corticosteroid can cause worsening or spread of that. Patients where you kind of drag your feet, but might have an indication if they continue to have exacerbations or have one exacerbation, more than 100, less than 300 eosinophils, you might consider it if the person's struggling and you want to try and help them out and see how they respond. So, this is a confusogram slide that really lists all the therapies, including the short-acting therapies, the monotherapies, the dual LABA/LAMA therapies, and the triple therapies. They all have different devices. Some of them are pure nebulizers, some meter dose inhalers, some dry powder inhalers. And we really have to pick the right treatment for the right patient. Theophylline, occasionally used in really advanced patients who are still struggling. The data really isn't very strong that it adds to appropriate guideline-based therapy. And some patients with a lot of cough, sputum production really have a strong bronchitic component. There's some data to support mucolytic therapy, and even over-the-counter N-acetylcysteine or Mucomyst can be helpful and tried with some, B-level data to support that when you've really done everything else. Again, in getting a patient in follow-up, you want to reassess their symptoms, shortness of breath, exacerbation frequency, make your decisions based on that. Assess their inhaler technique. Are they using it right? Do they know how to use it? Do they have the dexterity and the cognitive status to use it? Make sure you've done everything non-pharmacologically, pulmonary rehab, they've been vaccinated, they're on appropriate oxygen therapy, and then make a decision whether you should switch the inhaler, escalate to a triple, or in some cases when they're particularly stable, and consider de-escalating. And this is really the approach on the return patient. Next. So as far as treatment plan, consider oxygen therapy. We're certainly going to get a pulse oximetry or an arterial blood gas before we would start oxygen therapy. Optimize current pharmacologics, and we just went over the algorithm for that. Next. Assess their adherence and whether they can use the inhaler. That's critically important. So as far as long-term oxygen therapy, proven in the right patient to prolong survival. So that's one of the things we know can allow your patients to live longer if they have a saturation of 88% or lower. Less proven with exertional short hypoxemia, although no doubt some patients have symptomatic benefits by giving exertional oxygen, but that's more optional because really not proven to prolong survival. But definitely hypoxemia at rest warrants oxygen therapy. As far as being on guideline-based therapy with ICS in frequent exacerbators, we have the option of PDE4 inhibitors such as roflumilast and the long-acting long-term macrolides of azithromycin to consider. And with weaker data on N-acetylcysteine. All of these options have demonstrated efficacy in preventing exacerbations and should be considered. So back to our patient, the usefulness of pulmonary rehab really is unequivocal. There's been multiple Cochrane reviews showing improvement in symptoms, exercise tolerance, data supporting even survival. With our woman in the middle of somewhere miles away from healthcare, we're going to be challenged to find a good pulmonary rehab facility. So recommendations regarding connecting her with physical therapists or doing a minimal assessment in your facility to assess safety and then to give her a home exercise prescription on a treadmill might be helpful. But in folks that have access to pulmonary rehab, that's always something that should be considered. Pulmonary rehab for patients who've experienced exacerbations should be initiated less than 4 weeks following that exacerbation, proven to prevent prolonged or subsequent exacerbations. Patients with high symptom burden and risk for exacerbations should be encouraged to take part in formal rehab. That includes setting goals, and part of the therapy is teaching, optimizing their medications, addressing nutritional issues, psychological therapy. All these should be considered part of pulmonary rehab. There are some patients that, for whatever reason, tend not to be referred as much that we really ought to refer, and that includes older individuals, women, those, for whatever reason, that are more deprived, and patients with comorbidities and pain issues often are referred less for pulmonary rehab, and really everybody should be considered to benefit. Self-management is a concept that there's been a lot of studies. In general, when it's done the right way, it can improve the outlook in our patients. You should never do self-management in lieu of being available to guide your patients, but giving a patient a strategy when they begin to develop symptoms at home, including a prescription of steroids or antibiotics to begin to take under specific directions, is really important. And our patient did have this self-management plan and had self-treated exacerbations on 4 occasions, which may have circumvented hospitalizations. Although the patient likely had some education on COPD and its management, these things need to be reinforced on subsequent visits to make sure that they know how to use the self-management plan, and also to know that when they should call the office and not just things on their own. All right, so we're going to hand it over to Dr. Hahn and give some final comments.
Yeah, well, thanks so much, Frank. So we went over quite a bit tonight talking about the importance of symptoms, exacerbations, early diagnosis, and the need to do pulmonary function testing to confirm a diagnosis. We want to be proactive with care coordination, with personalized plans, and really a lot of the stuff in terms of self-management, nutrition, and education really can be accomplished through getting those patients enrolled in pulmonary rehabilitation. But like with everything else, I think it truly does take a village to try to provide good care for patients with COPD, and that's going to include doctors, nurses, respiratory therapists, exercise physiologists, et cetera. But the good news is that we have both pharmacologic and non-pharmacologic approaches, and that'll allow us to take a really holistic assessment of patients. So we have, Frank, we're a little bit out of time, and there are, we can only do maybe 2 questions. So I'm, if you don't mind, I'm going to toss you a question, and then maybe I'll do one. So here's a question for you, Frank. What do you think about providing appropriate, reliable patients with azithromycin to have at home if needed, especially during the winter when URIs are frequent?
Yeah, so I think that's a good self-management strategy. As long as, I always like the patients, if it's over the weekend, to start, but check in on Monday and let us know that they did begin their steroid or their antibiotic, and then just to touch base with us on symptoms. There was one VA study that actually showed a higher mortality rate with self-management, and I think that's because they cut the cord to the patients and they really had too much independence. So I think having it available, decreasing the lag to start antibiotics and steroids with appropriate direction is important, but still to have a cord connected to the center and the physician's offices.
All right. I agree, Frank. There are so many good questions over here. I'm sorry we cannot get to all of them. I'm going to just grab one more, and that is any tips on how to get a patient inhalers if there's high copays or insurance won't cover. So I would say, generally speaking, if the patient is under 65 and not on Medicare, there's a lot of patient assistance programs out there that, hopefully you've got a nurse or a clinic coordinator that can, or a pharmacy tech that can help you look into those options. For patients that are Medicare, obviously it depends a little bit on what they have or what they don't have from an insurance perspective. but for Medicare Part D. But what I will say is that one strategy I've used, and I'm sure Frank has done this too, is you can switch patients over to all nebulized medications, which is covered under a different part of Medicare, Medicare Part B. And sometimes you'll find that a patient has better Part B coverage than Part D coverage, and you can sometimes find more affordable options for patients that way. So I think we've all learned to get a little bit creative with prescriptions to try to help patients. Thank you so much, Frank, also for joining me. It's always a pleasure, and thanks to our audience for joining us tonight.
Thanks, Milan. Thanks, everybody.